Start, sir.
Good evening, everybody. Today we are here with second episode of INQUEST. INQUEST actually have started last month to face the unseen threat in critical care. We have had the debut session by Dr. Jitesh Govindan, and he was talking about amoebic meningoencephalitis. And today we are going to deal with recent H3N2 surge, which drives significant infectivity in India. We are having three expert who is going to discuss on the subject. So let me have the privilege of introducing the moderator of today's session, Dr. Jitesh Gangadharan. He is currently head of the Department of Critical Care Medicine of EMS Memorial Cooperative Hospital and Research Center Limited, Perinthalmanna, Kerala. Dr. Jitesh has done his MD from GMC Amritsar and went on to complete his DM in hospital medicine and the critical care from AIIMS Rishikesh. Then he has completed his MRCP from United Kingdom, UK. He has also done his certification in echocardiography from JROP and FCRS from ISCCM. He is having 20 plus publication in various index national and international journals, and his special interest lying in lung USG, infectious disease, ECMO, transplant critical care, and the cardiac hemodynamic. Welcome to the session, Dr. Jitesh.
Thank you, Saurabh.
And let me have the privilege of introducing very senior critical care specialist, Dr. Jacob Varghese, Dr. Jacob Varghese doesn't require any kind of introduction, but I'd just like to talk a little bit more about him. He is currently HOD and the senior consultant, critical care medicine, and he is also associate medical director of academics and the research of Rajagiri Hospital, Kochi, Kerala. So he has done his MD from Rajiv Gandhi University of Health Science, Bangalore, and he has completed his DM in critical care medicine from Sri Ramachandra University, Chennai. He has also done his EDIC. His experience is like this. He was senior resident in Department of Nephrology, Lizzie Hospital, Kochi, Kerala. Then he has become junior consultant in the Department of Internal Medicine, Lizzie Hospital. Then he has become coordinator in the DOTS program of WHO in the Lizzie Hospital, Kochi, Kerala. And then he has become junior consultant in the Department of the Critical Care, Sundaram Medical Foundation, Chennai, September 2009 to June 2009. He was assistant professor in Department of Emergency Medicine in AIIMS, Kochi from July 2009 to September 2011. And before joining Rajagiri Medical College, Rajagiri Hospital, he was the consultant in Department of Critical Care, Internal Medicine, Majumdar Shah Medical Center, Narayan Hrudayalaya, Bangalore from 2010 to 2015. Welcome to this session, sir.
Thank you, Saurabh, for this kind introduction.
Thank you very much. And let me have the privilege of welcoming Dr. Rajesh V, very senior pulmonologist, and I have been knowing Dr. Rajesh for almost a decade. Dr. Rajesh is currently HOD and the senior consultant in pulmonary medicine of Rajagiri Hospital, Kochi, Kerala. He has done his MD in respiratory disease and the tuberculosis from Goa Medical College, Panaji. He is the national level gold medalist in TNB examination in respiratory disease and tuberculosis in the year 2005. He has completed his IDCCM in critical care medicine from Apollo Hospitals, Chennai. His experience is something like this. He was assistant professor of pulmonary medicine in AIIMS Kochi from 2005 to 2006. He was fellow in critical care Apollo Hospital, Chennai from 2006 to 2008. And he was assistant professor of pulmonary medicine in AIIMS Kochi 2008 to 2010. He was also assistant professor of pulmonary medicine in AIIMS Kochi from 2010 to 2014. He was the recipient of Young Pulmonologist Award instituted by Academy of Pulmonology and Critical Care Medicine 2013. Dr. Rajesh V is working as the chief consultant in pulmonary medicine of Rajagiri Hospital, Kerala. So welcome you, sir.
Thanks a lot, Saurabh.
Thank you very much. So without much ado, I just would like to hand it over to Dr. Jitesh, the moderator of today's session. Thank you. Over to you, Dr. Jitesh.
Thank you, Saurabh. Thank you. So let's start. Good evening, everyone. A warm welcome to all of you. We'll begin today's scientific session with a presentation by our senior consultant, Dr. Jacob, sir. Then, following this task, we will transition into a panel discussion with both considering both pulmonology as well as critical care perspective. So, without any further delay, over to you, sir.
I'll just share my slide.
Yes, sir.
Is my slide visible?
Yes, sir. Your slides are visible.
Okay. Okay. So, good evening, respected panelist, Dr. Jidesh, Dr. Rajesh, and the micro and the team, and all the people have joined. So, this particular INQUEST second edition is about what is happening, the current trend or the trend which has slightly changed, but it can come back in the December Jan section because of the seasonal variation. What is called as that H3N2, the influenza virus H3N2 surge in India, the unseen threat. So I'm representing the two other panelists in presenting a brief presentation before the panel discussion. The COVID pandemic has definitely masked the influenza infection for maybe 2 to 3 years, but it has come back again right now. So the influenza, the classical classification is divided into 3 types, the influenza A, B, and C. Of this, the A1, the first one, the A1 is something which is responsible for almost the large pandemic across the continents and significant mortality in young adults. Influenza A constitutes the H1N1 infection, which was a pandemic in 2009 to 10. You must be aware of that. And influenza A, the subtype is also H3N2, which has got a significant threat right now in the influenza infections we see in our daily practices. Because of the fact that it has got the antigenic shift and the drift, which you learned in microbiology, makes influenza A really one with pandemic potential. And the host ranges from the humans, the swine, the equine, the birds, and marine mammals. The swine flu was the name given to the previous H1N1 in 2009 and 10. Whereas influenza B, it is predominantly affecting the humans. It has got only antigenic drift. That is why it doesn't have much of a pandemic potential. It has causes severe disease in children, elderly, and causes most of the endemics in many regions. Influenza C, it is only, again, antigenic drift, but it just causes mild disease without much of a seasonality. This is a slide which explains the concept of the antigenic drift and shift. What I would like to emphasize upon is that antigenic drift is a mutation which causes mainly epidemic, the influenza B, which I explained there. Whereas antigenic shift is a one thing which causes reassortment and it ends up in pandemics, H1N1, H3N2. With influenza A is notorious to cause both drift and shift and the pandemic. But influenza B and C, mainly the epidemics only. And in the left hand of the slide, you see how do they name the viruses. If you look at the naming of the viruses, the first one, what is called as a ABC, is a virus type. The second one is based on the place it is isolated. It has got different name. It could be Austrian, it could be Sweden, it could be in Sydney, if it is isolated in the Sydney. The naming is important because the vaccine comes every year. The vaccine strains are based on the virus isolated in the particular region. And the strain number is 05, the next one. Year isolated is 97. This is 97 virus, that is it. And the virus subtype, influenza A, under influenza A, we have different subtypes of this H3N2 and H1N1 are 2 common things which you must be aware of it. This is how it has been classified. And the influenza A story is multiple. We have the H1N1 pandemic in the previous years, and all of you remember the 2009 pandemic, which has got high risk of mortality. And then the COVID-19 pandemic impact the influenza surveillance because we are all behind the COVID-19. And now in 2022-24, the H5N1 outbreak has come, and now the H3N2 and H1N1 again is resurfacing in multiple countries, not as a pandemic, but it is an epidemic in multiple countries. And this is a seasonality. If you look at the 2 seasons over here, The first is a northern hemisphere, where October, March is a time, where we get the most of the infections because of the cold climate there. And in the southern hemispheres, where the Australia or the continent of Africa partly comes, they get into April, September. If you look at the India in the middle, because India in the middle, we have both northern and southern region. That is why in the northern part of the India, maybe the peak season is somewhere in the cold climate, the winter climate, whereas in southern part, like southern state, especially in Kerala, Tamil Nadu, probably we have this peak season in April, September. In Kerala, especially, we have the post monsoon, the peak of monsoon, July, August, we get the maximum number of influenza. The seasonal variation you see over here. And in India, the thing is that throughout the year you get, because it comes in the middle. And 97% of influenza A, the subtypes is H3N2 and H1N1, and that is almost equally represented currently, whereas H1N1 was there before. Now H3N2 is definitely getting into a lot of significance. And why influenza A spreads across many species? The multiple reasons I mentioned about antigenic drift and shift, and it can circulate in many animals and humans, pigs, birds, compared to influenza B. And because of increased reassortment, antigenic variability, and increased circulation, the influenza A just can spread compared to influenza B and C and have pandemic potential. Now, pathogenesis largely spread by droplets, surface, hands, and aerosol. Incubation period is 1 to 4 days from time of exposure. The transmission from first day before to 7 days after the symptoms is a transmission time. High risk group. There are certain group of people which are high risk, especially children 6 months to 5 years, adults more than 50 years, obese individuals, BMI more than 40, chronic kidney disease and dialysis patients, healthcare workers, and the patients with heart disease, with chronic lung disease, heart disease, including asthma and chronic liver diseases, immunocompromised persons, and pregnant patients. So these are the group where high risk of developing into infections and the complications. Complications will come to it a bit later. This particular slide needs attention because this is a data published in NEGM in 2020, where the increased incidence of hospitalization due to acute MI, the influenza A, the risk of developing an acute MI with an influenza A is going to be very high. The influenza, not influenza, influenza infection, 6.05 compared to other viral types. And also the patients with heart failure, influenza infection is associated with high increase in hospital mortality and morbidity, where the mortality also has got significance. Acute respiratory failure, the precipitating acute respiratory failure in patients with heart failure, influenza patients have got high risk, which is statistically significant. Again, acute respiratory failure, recurring mechanical ventilation, acute kidney injury patient, acute kidney injury requiring dialysis. So all kind of disease spectrums, the endocrine dysfunctions or organ function worsening in patients with heart failure, influenza A is got a reason for that. Influenza infection, especially influenza A, which has been commonly seen, has got a increased incidence of risk factor. With regards to MI and with regards to myocarditis, we are seeing increasing incidence of these two complications with influenza infections. And the replication of viruses, this is basically been mentioned to see the targets. If you look at the replication of viruses, the virus get absorbed into it and uncoating happens. At the area of uncoating, we have the first the antiviral drugs, which is amantadine, which has been used before, where it blocks the uncoating, but not used nowadays because of increasing residence. What commonly used drug is our neuraminidase inhibitor, where oseltamivir and peramivir is there, which basically causes the release of virans has been inhibited. The release of the virans from the thing is inhibited by this neuraminidase inhibitor. That is why the mechanism of action happens here. Another two drugs, one is new, one is used in COVID, was favipiravir, where favipiravir prevents the replication of RNA. Favipiravir needs to be phosphorylated and it prevents the replication. And another drug is called as baloxavir. Baloxavir prevents mRNA elongation and further assembly of viruses. These are the areas where the drugs act, but commonly used drug and widely available is oseltamivir, which prevents the release of virans from the cells. And clinical features, You have same like any other virus. Differentiation may be difficult. Fever, myalgia, headache, pharyngitis, and 5 to 7 days of acute illness. Full recovery may be prolonged. Most adults are infectious from 3 to 5 days after symptom onset. Children can be infectious for 10 days or more. That is why children go to school, they come back with an infection, and elderly has got a higher risk of that. Immunocompromised patients also can shed viruses for several weeks. The definition of viral infections is like influenza-like illness, ILI, where the fever, cough, and onset within the 10 days. Where when you call it a severe acute respiratory infection is basically the same fever, cough, onset within 10 days, and who requires hospitalization, we classify them as severe acute respiratory illness, where otherwise in OPD practices, we call them as influenza-like illnesses. And what are the complications? One of the common complication is respiratory failure, primary respiratory influenza pneumonia, respiratory failure, 10 to 10%, very high, common in high-risk group, which includes patients with comorbid state. Secondary bacterial pneumonia. See, influenza primes the lung tissue for bacterial infection. So secondary bacterial pneumonia is most common complication. Patient may initially improve after that and then worsen. Most of the times, the patient with high-risk groups, any of the infections, Staph pneumonia, Staph aureus, H influenza. In the H1N1 pandemic, Staph aureus infections was very common, whereas in H3N2 and the current pandemic, any infections are common. Look at the complications of H1N1 in the influenza infections, especially H3N2 and H1N1. Apart from the common things, we have neurological issues where Guillain-Barré syndrome, GB syndrome, demyelinating polyneuropathy has been reported not very uncommonly. And myocarditis, as I mentioned, is very common, especially patients increased risk of MI or increasing risk of heart failure patient ending up in organ complications. You may talk about musculoskeletal. Couple of cases we have seen post-influenza developing rhabdomyolysis going in for severe renal failure. Others, respiratory ended up in pneumonia or exacerbation of lung disease or secondary bacterial infections are quite common. So GB syndrome, cardiac involvement, and rhabdomyolysis are three uncommon things which we are seeing. Ray's syndrome is common in children. This is something we should be very careful about. And we have seen a lot of cases of fungal infections nowadays post-COVID, even post-influenza, because virus and funguses, I think it is a situation where we need to be aware of it. It can complicate any respiratory disease. If you look at the diagnosis of invasive aspergillosis, the ERTC guidelines start with an immunocompromised people. But that's not the scene. In a patient who is immunocompetent, who was infected with H1N1 or H3N2 or influenza-like illnesses, they have a high risk of developing a fungal infections. So the diagnostic barriers include less use of bronchoscopy, low sensitivity of serum galactomannan. It's going to be a difficult thing. So somebody is not improving, lung patches are persisting. A bronchoscopy is nowadays warranted at the earliest to differentiate between the bacterial or a fungus, and you need to consider early antifungal things are not improving because fungus post-viral mortality is going to be very high. When to suspect, I think in winter period, seasonal period, classical symptoms, influenza-like illnesses, and high-risk population, they comes like pregnant people, and PLHA means patient living with HIV and AIDS, and any acute exacerbation in the seasonal conditions and coming with the complications, you need to consider the possibility of a influenza infection and needs to go for diagnostic test. Sample collection, I think you all know, nasopharyngeal swab, oral swab may not be required. But one thing I have to emphasize is that when you take an nasopharyngeal swab, don't use a cotton-tipped stick. The cotton can inhibit the PCR assays. That's why one message I have to give. And use mainly flocked swabs or alginate swabs. Both nostrils you will take. You put it in a viral transport medium, transport in a lab to an ice. Delay in transport, you can store it in the fridge. And rapid diagnostic tests where you check antigen, same like COVID antigen is being employed. But we have the PCR assays, which is equally the turnaround time is going to be equally same. So you don't need to use an antigen test because PCR is widely available right now. Molecular assays holds the key. We have rapid molecular assays and the classical assays. Rapid assays are good. Again, the TAT10 can be a bit earlier. The problem with rapid molecular assays is that they can differentiate between A and B, but under the A, it may not be able to tell you which is H1N1 or H3N2. Similarly, in molecular assays, that is the gold standard of detection, it can also differentiate between A and B and also tell us about the subtype of A, which is H1N1 or H3N2. And multiple assays can be simultaneously detect other pathogens in single sample. Whereas you have the respiratory syncytial virus, RSV, is slightly going up. We can diagnose that also. This is a classical amplification plot they gave for the cycle threshold for us to come to a conclusion. This is the Rajagiri data which I would like to show it here from Jan to October, where you have, if you look at the spectrum of H3N2 infection compared to influenza H1N1, influenza B, and RSV. Now, post monsoon, I mentioned to you earlier that India has got around the clock, around the year infections, where south part may have an infection spike post monsoon. That is why in July, August, if you look at the numbers of H3N2, it is definitely 241, 180 cases of this. Some of them required ICU stay in a very severe state. Slightly coming down in September, October. I think we might have a peak in the December section. I think all of us are experiencing some sort of a respiratory, and we normally go and check respiratory syncytial viruses. Please note that is slightly increasing in the September, October months, but still H3N2 infection is not gone out. Compared to H1N1, H3N2 in the current 25 has got an increasing numbers and a peak in the south, or in Kerala it is immediate the peak of the monsoon, whereas things can change in the northern part, North India, where the winter is going to set in November. You're going to have a rise. Management, send for the investigations and treat as soon as possible in hospitalized patient where severe complicated progressive illness, patient with risk of complications and immunosuppressed patient, children less than 2 years, adult more than 65, and pregnant females or within 2 weeks of postpartum. You don't need to wait for anything. Start it off. Can consider antiviral in non-risk outpatients with ILI or symptomatic healthcare workers at high risk of developing complications. Because healthcare workers were exposed to it with a high risk of developing complications, maybe send a swab or start treatment at the earliest. Antivirals available, I mentioned to you, commonly used drug is the neuraminidase inhibitor, where we have three things, oseltamivir, zanamivir, and penamivir, where we have commonly available is oseltamivir. The other two drugs are baloxavir, which is a new kit, which is availability is a question right now. Amantadine and remantadine, previous drug not recommended right now because of high levels of resistance. And this is you don't need a combination therapy for H1N1 H3N2 infection. Oseltamivir is a drug, 75 milligram. BD is for 5 days is the recommended dose. Zanamivir is mainly in an inhalational thing, and penamivir is an only injection available, which is 12 milligram per kg. And baloxavir, as I said, it's a weight-based thing, 40 milligram, 80 milligram per hour for a single drug. Longer treatment is required, more than 5 days in immunocompromised patient, those with pneumonia or ARDS. An adjuvant therapy like steroids, like recommended for pneumonia or IVIG, even if it is pneumonia ARDS, is not recommended in patients with influenza, H3N2 and H1N1 infections. Additional measures, you need to isolate the patient, droplet precautions for 7 days or 24 hours till resolution of fever respiratory symptoms. Pregnant patient, start as soon as possible oseltamivir. Baloxavir, even if it is available, not recommended because data is not very clear. Hospitalized, immunocompromised, oseltamivir is a standard of care. And duration of treatment, I said 5 days is minimum, but if the viral replication is more, PCR is still positive, or risk of emergence or chronic patient with comorbid state immunosuppressed, you need to do it for more thing. And if there's a clinical deterioration despite treatment, the virus shedding or the viral infections may be the primary reason, but please do consider secondary infections with bacteria and fungus, and then also consider resistance as a possibility. Newer drugs, just a word, not available in India. This is a leninamirv octanate, is a inavir, is a nasal or an oral, this rotahaler inhalation things, which is available in Japan. They say, it's a 40 milligram or 20 milligram with children. Once a single oral dose, effectiveness is good, but we don't have much of it. Baloxavir, I mentioned there, it is something which is a different action, not acts at the replication site. It acts against influenza A and B. Where is it important is that if lack of response can be resistance, and resistance is confirmed by typic studies, then we may have to consider other drug. Baloxavir comes into picture over there. No hepatic renal modification with baloxavir. Availability in India is a concern always. A touch on vaccine before I conclude. I think this particular WHO FTC recommendation 2025 vaccine composition, you have seen that they mentioned about A, B, the site, the Croatia, Austria, where the country where it has been, it has been identified, or the place identified. That is why the name comes, and then the strain year comes, and which type, H3N2. The quadrivalent vaccine, which is currently available, has got 2 influenza A, which is H1N1, H3N2, based on the country and the location thing they have made it, and 2 influenza B, which is Austria and Phuket. So it is every year the vaccine strains based on the typing, based on the availability, it is going to be changed. And 6 months, kids more than 6 years, people with who should take it? People with this is the Ministry of India recommendation. Healthcare workers working in high-risk groups, ED, ICU, pregnant women, people with chronic disease, COPD, heart disease, liver, kidney, COPD, cardiac failure patients, patients with chronic diseases, asthma, blood disorders, CHD, and elderly people more than 65. The age may be a bit less nowadays, and 6 months to 8 years. Children needs to be vaccinated for the reason that school-going children, especially, they get infection from the school, and elderly people who has got a comorbid state in the house may get infected, and they get into the ICU. So if you look at the history of all the H3N2 or H1N1 infections coming right now, everything start with they will tell the history that the child brings it from the school, and then everyone is infected. That is why children more than 6 months is vaccinated, not only to protect them, but also to protect the family and the society. That is what is vaccination is important. And in influenza vaccine in India, there are some paper reports or some discussion happening by does India request 2 schedules of vaccine, because physically it is in northern hemisphere as per the zones, but the seasonality is distinct related to latitude and environmental factors, the rains I mentioned over here. So probably consider September to October vaccination schedule for cities with temporal seasonality, where the December, October, where the peak season of infection is in November, December, the North Indian group mainly, and in South states where April, May, the vaccination schedule for cities with the peak monsoon season in July, September, where the peak happens in June, July, August. So the vaccine can be given in April, May. This is recommended by Government of India 2020 guidelines, but the availability of vaccine usually comes in September, October. We have the current strain which is available right now in 2025. And I think vaccination campaign is something which is recommended for every OPD and the pulmonologists and physicians who are attending it needs to campaign. Need to inform the patients about the need for vaccination, which is a good public health initiative. So with this, I end my talk. Thank you so much for a patient hearing. Over to Dr. Jidesh for taking it further. Let me stop slide sharing here. Yeah.
Yeah, sir. Thank you, sir. Am I audible?
Yes.
Yeah, thank you so much, sir. That was an excellent and informative presentation. Now we will move to the panel discussion. So before that, if anyone has any questions, please drop them in the chat box so that we will address it towards the end of the session. So my first question is to Dr. Rajesh. Dr. Rajesh, sir, am I audible?
Yes, very much.
Yeah. Sir, my first question to you, sir. Based on the current epidemiological pattern, do you think this virus has a potential to evolve to a pandemic, or are we more likely to continue seeing sporadic localized outbreak? What do you think, sir, regarding this thing?
I mean, that's anyone's guess, but I feel it may not really translate to a pandemic. The major logic that I say that way is that this is something that has been there for years. Maybe there are antigenic shifts and drifts and all those things that are happening, but it may not. And we have reasonable vaccines. Of course, if there is a major antigenic change, the existing vaccines may not have that protective efficacy. Besides COVID, if we see, it was a totally new virus. We didn't have any clue of its antigenicity and all those things. We didn't have any vaccine. Besides that COVID pandemic, I feel it may not. The H3N2 may not translate itself to a pandemic. Probably it will have a huge regional impact in almost all areas of the world, but not a healthcare consequence to that extent, if you look at the healthcare utilization or mortality.
Okay, sir. Thank you. So, sir, my next question is to you only, sir. Sir, is there any specific way you are able to clinically differentiate it from the other viral flu-like presentation? And there is one more question to that. What all are the red flags that you will see that you will consider for an early referral for an ICU when you encounter such patients in an OPD or an emergency?
Okay. I really haven't seen much difference between all these seasonal viruses. Like if it is influenza A versus influenza B, influenza A, whether H1N1 versus H3N2. Of course, there are a few studies which have tried to dissect out some differences with very, very low sensitivity, I would say. There are some papers which say that H3N2 tends to be slightly more virulent, the hospitalization rate tends to be slightly higher and all. But by and large, I don't think these are symptoms that are, clinical features significantly overlap. And from a therapeutic point of view also, it may not matter much because H1N1 versus H3N2, you have almost overlapping drugs for treatment. If you consider specific treatment and supportive treatment is more similar. So that's the first part of it. The second half regarding the red flag signs, I think this is much more clinically important in the practice scenario. Sitting in the OPD, someone who has multiple medical comorbidities, who is otherwise itself a sort of vulnerable person, age, multiple medical comorbidities, someone who has extreme prostration, like very high fever, toxic, who is not eating properly, someone who is hypoxic, those things I probably tend to hospitalize. I may not directly refer to the ICU at that stage, but I will tend to hospitalize. And after hospitalization, if there is a secondary worsening, and again, someone who is febrile for more than 3 to 5 days, maybe someone who is febrile for more than 5 days, not subsiding trend, again, I will tend to hospitalize that person. And someone who is hypoxic, who is significantly symptomatic, I probably would take an upfront chest radiograph to see whether there are any pneumonic patches. And maybe someone who is significantly hypoxic, hypotensive, someone with altered sensorium, definitely I might think of upfront ICU reference and ICU care. Otherwise, someone who is worsening, having a secondary worsening after hospitalization, definitely I will get the critical care team also involved.
Okay, sir. Thank you. So next question is to Dr. Jacob, sir. Sir, out of the H3N2 cases that require intensive care, are you seeing more of a typical pneumonia-like presentation, or are you seeing more of an atypical presentation like refractory hypoxemia, myocarditis, or you are seeing more of secondary bacterial pneumonia? What is the presentation that you are encountering, sir?
Primary pneumonia like what we saw in H1N1 pandemic is not very common with the current H3N2 infection. What we are seeing predominantly is what I mentioned in the slides, that worsening of the underlying comorbid state, especially with regards to cardiac status. The myocarditis part seems to be in an increasing number. Patients with compromised cardiac function or a previous history of any cardiac disease is there, they tend to be more developing into a worsening heart failure. That is a group of people which ends up in ICU requiring hypoxic respiratory failure and support, whether with NIV, HFNC, and then go on a vent. And then end up in, and the third most common thing is post-viral secondary infections, which is definitely in the rise. And I have to mention that fungus, early diagnosis is important to differentiate between is it a worsening due to the bacteria or a fungus, which warrants the treatment, which makes a big treatment differences. So 3 scenarios which I would like to put over here.
Sir, like you are already told about the bacterial as well as the fungal pneumonias are possible in this scenario. Do you, what time do you go for any markers like procalcitonin, or you go for any fungal markers at this particular stage? What is your practical take on that, sir?
The primary thing is that I need to confirm that whether the virus shedding or that's immunocompromised people or immunosuppressed people or people with comorbidities, are they shedding the viruses? So oseltamivir treatment needs to be continued for that group for longer time. The second thing is that if definitely maybe a chest imaging, a CT scan will definitely give us a picture. Early CT imaging will definitely help to differentiate looking at the shadows, whether it is predominantly a lobar consolidation or predominantly a bronchopneumonia pattern, where sometimes you can differentiate the pattern looks like more of a fungal or anything. Coming to the blood markers, it's a difficult call. Procalcitonin, if it is localized to the lungs, it may not go up a larger extent. So we may not be able to differentiate between with regards to a blood markers. And if the lung shadows are persisting, the fever is persisting, patient is still requiring ICU stay or hospital stay with oxygen requirement, and early pulmonology team, we have a good understanding that pulmonology team is involved, and definitely an early bronchoscopy and bronchoscopy is a key, which definitely can tell us what we are dealing with and based on antibiotic respectively. If it is not the case, if it is still the patient is, if not rapidly worsening, I still consider the primary issue as a problem and continue oseltamivir with organ support for this kind of group of people.
Okay, sir. Thank you. Sir, next to Dr. Rajesh. Sir, in the pulmonology OPD standpoint, sir, what like once you get a case of suspected H3N2 or influenza, what pattern you usually follow? Do you start directly on oseltamivir and send sample, or you will wait for the reports to come positive and then start sample, start oseltamivir, sir? What do you do?
I think someone who is very stable, just has a fever, sore throat, maybe a cold-like symptom, no other comorbidities, young, healthy gentleman, no hypoxia, no lung shadows. I'm comfortable for nature to take its course and heal. But I definitely would tend to err on the safer side, someone who is at the extremes of age, someone who is having multiple comorbidities, having severe disease. As a general rule, anyone who requires hospitalization upfront, we start empirically. In that season, we start empirically on antivirals. We won't probably wait for the report of the cell. Of course, if that is negative, we can always stop and such stuff we can do. But if someone is sick enough to get hospitalized upfront, we tend to start and send the investigations.
Okay, sir. Thank you. Now, next to Dr. Jacob, sir, from ICU perspective, sir, actually, I want you to like, sir, do you routinely go for HRCT in every patient? And like, do you usually rely on the nasal sampling, or you go for a invasive respiratory sampling? What do you do, sir?
Nasal sampling, no invasive sampling in the beginning. If at all, they can suppose example, they have got a cardiac failure with preserved ejection fraction coming in with hypoxic failure. Primary reason is the H3N2 or H1N1 infection complicating the cardiac failure, as a slide I mentioned there. Now, nasal swab is the key. Nasal swab will be definitely sent both nostrils. I told you no cotton, only that flocked thing will be sent, and then that gives us a diagnosis. Only if the symptoms are persisting, fever is persisting, X-ray shadows are remaining after adequately treating the cardiac failure, then the question of CT happens. Upfront CT, I don't think it is recommended. We need to give adequate time for the virus clearance and the symptoms to settle down. If not improving, then go to the next level, which has got three possibilities. One, viral pneumonia itself is persisting. Second, the secondary bacterial or fungal infection. Third thing, the rare possibility, which is the resistance developing for the oseltamivir, which is not very common, but maybe it can be still a possibility.
Okay, sir. Thank you. Now to Dr. Rajesh, sir. Sir, in OPD practice, what treatment do you usually practice? You still stick on to oseltamivir, or are you started to use any of the newer drugs that sir has already been mentioned? Are you starting any of that, sir?
I haven't really started any of those new drugs. I still stick on to oseltamivir. Having said that, I don't know whether we have. I think Jacob gave a very good institutional statistics of the proportion of H1, H3N2, RSV, and all those things. But I don't think we really are doing resistance testing for oseltamivir. We probably look at the clinical improvement, and if there is no clinical improvement, probably we look at, as Jacob said, be more aggressive with HRCT, because HRCT tells you many funny things. It may show you infiltrates that are not seen in the chest X-ray at all, or it may be showing some pulmonary thromboembolism and all those things that can cause delayed resolution. So if CT chest shows some focal shadows, then probably go ahead with the bronchoscopy and look at the secondary bacterial, especially Staphylococcus, some of the hospital-acquired gram-negatives, and very importantly, fungus. So if these things are not there, probably I will still go ahead with the oseltamivir. I don't think I have enough data or knowledge on oseltamivir resistance as of now.
Okay, sir. Okay, sir. Now, next question to Dr. Jacob, sir, regarding the ICU management, sir. Like, one thing is regarding the dosing of oseltamivir, sir. Like, actually, you have mentioned that 75 mg BD is the one dosing. Actually, there are some studies have also mentioned a dosing of 150 mg BD. Do you use that? And the second one is regarding the IV antiviral drugs. Do you use that? And the other thing is like, sir, do you follow a early intubation or a delayed intubation? And what pattern of ventilation do you follow when you are planning to ventilate these patients, sir?
Okay. The first part, the dosing of oseltamivir. 75 mg BD is the recommended dose before. During the H1N1 pandemic, when a lot of death were happening, there are some recommendation came to double the dose to 150 mg BD, especially in the pregnant patient. That is what the recommendation came. But I think after that, there's a couple of studies which has published, which clearly states that you don't need the dose of double dosing in patients. 75 mg BD is a prescribed dose. maybe institutional centric approaches, some ID physicians do support 150 mg BD, but I think here we are following the standard guidelines, which is 75 mg BD for 5 days. And if immunosuppressed or patient with high risk group, patient is not improving, maybe will pneumonia and ARDS, you will continue treatment for a couple of another 5 more days, depending upon the clinical recovery. With regards to intubation, I think it's like say any other group of patients, we tend to use the non-invasive techniques in the beginning, especially the HFNC has definitely come a longer way because high flow nasal cannula is a preferred thing. The first line up, or most of the patients definitely will come good in high flow nasal cannula, and if possible, the self-proning has been encouraged, same like the COVID thing, which definitely can improve the oxygenation if possible. And as I mentioned, that the worsening of the infection, one of the possibility will be an additional cardiac failure. Need to look clearly into that aspect, especially patients with diabetic, patients with heart disease, diastolic dysfunction getting into a pulmonary edema also may be contribute. So be very careful in fluid management. You don't need to give judicious in giving IV fluids, and keep an equal balance is a key which we maintain, because that can definitely worsen the hypoxia if we're not managing that. In case patients are not improving, oxygenation are worsening, and the PF ratios, we do go by PF ratio coming less than 150. And of course, the work of breathing, that's one thing which we'll look into it. The respiratory rate, the work of breathing, and the respiratory mechanics is worsening. That is a time we'll consider giving for a invasive ventilation. And same like the protocol we follow for H1N1, COVID, ARDS, we manage with volume control ventilation, ARDS protocol with driving pressures and the plateau pressures keeps under 30 and driving pressure under 14. That is what we normally do. Possible to keep it. If not possible, early proning the patients. I don't think the current pandemic has given us, we have a lot of cases like in ARDS. We had ARDS cases, but all settled with invasive ventilation, and a couple of them only we have to prone the patients in the July, August time. Current October, November, now September, October, not many develop any viral pneumonia as normally see. ECMO, again, not used in this current pandemic, but I think if not improving, probably early venous ECMO will be another thing. But I would like to emphasize upon the myocarditis part. People are developing severe myocarditis. It's a group of people which deteriorate faster because they have a cardiac dysfunction also contributing to it. So that kind of people might require early intubation.
Okay, sir. Thank you. Sir, and my next question is to you only, sir. Do the antivirals continue to offer any better outcome? Like, do they prevent the progression from mild pneumonia to ARDS? What is your take on that, sir? What's your clinical experience? Like, does the antivirus really help?
The early antivirals definitely have an effect because people who started late antivirals is a group of people who ended up in viral pneumonia. So if you're suspecting a high-risk patient, high-risk group people, and fever not settling, the sick, but I just mentioned in the OPD practices, even if you see a persistent fever, persistent cough, or definitely looking tired, I think we need to send off the sample and start oseltamivir at the earliest, because early antiviral do prevent the risk of developing into complications.
Okay, sir. Now, next question is to Dr. Rajesh, sir. Sir, from a public health standpoint, what is the role of seasonal influenza vaccination, particularly to high-risk group like elderly, diabetic, COPD, asthma, and pregnant women? What is your take on that, sir? And also, I want you to specifically mention regarding the healthcare workers who are working in the emergency as well as in the critical care. What do you recommend?
Okay, I think this is some area where I will just love to dwell for around 2-3 minutes and maybe share a few slides. But if the take-home message, if any, after this webinar would be that influenza, whether it is H1N1, whether it is H3N2, whether it is influenza B, it is a preventable disease. It should be prevented. We have effective vaccinations. Not the mortality alone, the morbidity, even the work, in the sense the days lost from work is much decreased, to the extent that even employers are now recognizing influenza vaccine to their employees as a cost-effective strategy to improve workforce. We'll just share a few slides here of, I think Dr. Jacob had mentioned that, but a few things on a minute. I don't know whether these things are visible.
Yes, sir. Yes, sir.
Okay. A few things. So there are a few queries regarding these things. Whether trivalent is better versus quadrivalent is better. Here, I would say that if available, quadrivalent is always better because the quadrivalent contains two influenza A and two influenza B lineages. So even the trivalent contains two A and one B. But the B lineage that circulates across the globe every year keeps on changing. So the chance that you will cover the B is much higher if you get a quadrivalent vaccine. That's the first thing. So versus quadrivalent and trivalent, if quadrivalent is available, go for that. One. Secondly, northern versus southern hemisphere strains. Actually, we keep on talking, but in most of the years, there is no much difference between the northern and southern hemisphere ingredients. So this was 23-24. I think this is changed in 2025. Other than Darwin has changed to Croatia, but otherwise it's more or less similar. So the northern and southern usually in most of the years don't change that much. So the motto here is just get vaccinated. Don't think of whether southern is available, northern is available. Even Jacob showed that India occupies a unique position between the other than the northern and southern. So that's the second thing. And the third thing would be, what would be the ideal time in India? So this was actually a survey taken in various areas from India, and the proposed vaccination timing, there was a center in Alapi actually, and what we feel that in Kerala after monsoon is the major challenge along with the winter. So it may be better off to give the vaccine if it is available by April, May. That will be a good strategy. And there are even key opinion leaders who think that in Indian conditions, we are worthwhile giving two influenza vaccines a year, one in April, May, and one in October. So, I mean, these are some of the thought processes that go on with influenza vaccine. I think I will just unshare. So, I think the most important motto at the end of this is that we need influenza vaccine for anyone who has high risk, including pregnant ladies and all healthcare workers. That's what I would say. I think Jacob would agree.
Yes.
Yeah,
Yes.
I definitely agree, Jitesh, because we have a data from the HR, like 2023, we have the absenteeism or the fever clinic or the the healthcare clinic was fully flooded with people who were taking leave because of this thing. And now we formed a vaccine campaign, the influenza vaccine campaign, the infection control, because I happens to be the chairman of infection control. I think the data from the pulmonology OPD also was a big boost to us. Dr. Rajesh and team is the preventive vaccination schedule planning. They are doing it in the pulmonology OPD is phenomenal in our hospital. So we took a clue from them, and then HICC worked relentlessly with the management. And if you ask me, what we have done is that we have given the vaccine for the employees and the family for a low cost for a particular period of time. And 400 to 500 people were able to take that thing. But I mean, how much you will tell, the post-COVID, the vaccine resistance is going to be huge. So we can't compel upon people to take it. We just tell them what is the importance of vaccine. And people have taken vaccine in 1 year, definitely will take it next year because they feel the differences. So that is the way the message is going to spread. We have reduced the price to more than half the amount for people, employees and the dependents, not only for the employees, because everything starts from the school. The school children comes. So not many have taken it, but the numbers are steadily going up year by year. So probably, the healthcare institutions do have to consider, because employee health needs to be a priority, and influenza vaccine is an yearly vaccine which needs to be promoted.
Yes,
I think
sir,
it's very cost effective also, Jacob, because as you said, it really decreases the sickness absenteeism among employees. So I think it will be lucrative for even corporates. And as you said, someone who has resistance is only during the first shot. Next year, he will come back and ask you for the same thing.
No, sir, this is actually a very good initiative to provide the medication for at a lesser rate for the employees so that it gets promoted. That's a very good initiative, sir.
Employees and dependents.
Yeah, dependents.
Only a particular time of period. They have to register in that time and take it. Not they full throughout the year. We can't give it. That's a problem.
Yes, sir. Actually, that finishes my set of questions. There are few questions in the chat box actually. Sir, like, do you usually keep any suspected flu case isolated? What's your isolation policy regarding?
It's difficult to keep everyone isolated right now. No, suppose, but I'll try to keep, I see cubicles are there or separate area is there, you keep the patient in that area. And, even if isolation rooms are not available, the classical thing is that non-AC rooms with the windows open is something which definitely will help you. So same like COVID, we can request isolation, no doubt about it, but we can't keep it like that because it's not going to substance. So a single room may be a good thing. Don't keep it in a shared room. And ICU, try to keep it in the patient in the cubicle if it is available.
Okay. Sir, one question is regarding the how long H3N2 is contagious. Like it is usually 1 day before symptom appear, it will be start to be contagious.
Yeah, and 7 days from
Yeah.
the symptom onset or 24 hours after the fever and the respiratory symptoms, whichever is longer. That is a classical thing.
And in children and immunocompromised, it goes up to 10 days, right, sir?
10 days, yeah, 10 days. Immunocompromised, it can go up to 10 days. 7 days from the symptom onset or 24 hours post resolution of fever and respiratory symptoms, whichever is longer. Children immunocompromised up to 10 days.
And one question is regarding whether to use steroids or not. Steroids are usually contraindicated. Like
I mentioned that steroids IVIG is not indicated. No recommendation to use it in even severe pneumonia patient or patient with risk factors.
So, sir, that finishes the questions in the chat box also. And thank you so much, Dr. Rajesh sir and Dr. Jacob sir, for your clarity and insight. And thank you, audience, for your active participation. So basically, influenza cases are increasing now. So whenever you encounter a pneumonia, always keep it in your mind. It can be a possible case. So go for testing, and most importantly, vaccination is the strongest tool that can be we have in our hand. If we vaccinate properly, the incidence of the cases can be decreased, and that's it. So thank you, everyone. Thank you, sir.
Thanks a lot. Thanks, Jacob, and thanks, Micro team.
Okay.
Yeah,
Sir,
thank you.
I guess we finished on time, sir. We finished it in 40-45
Yes.
minutes. Like it's yes, sir. That's very good, sir.
Absolutely, it was informed. So beautiful presentations and so beautiful discussion. And on behalf of Microlabs, I would like to thank you, our esteemed panelists, Dr. Jacob and Dr. Rajesh, for taking us very in depth on this H3N2. Even though the infectivity is rising pan-India, but the message is very, very clear from this particular discussion that it is preventable and we can actually save more working hours for the working people, and including the children also we can actually prevent that. I would like to thank Dr. Jitesh for beautifully moderating the session and asking so insightful questions and driving this particular discussion to a very, very informative session. And I again, looking forward to having all of you in our very next episode. Today we could reach out to almost 100 participants live, and I'm pretty sure that who couldn't make it up in the live session, they would definitely find the YouTube session or YouTube video very, very informative to refer to for their future learning and for enlightenment. So with that, thank you very much and wishing you a good night. Take care and see you next time.
I forgot to acknowledge someone. Sorry, I have done it in the presentation. My slides and presentation, definitely it is difficult for a short time to do it. So the ID physician, Dr. Imtiaz, the ID physician who is in Rajagiri, Dr. Rajesh knows him. Dr. Imtiaz, I think he may be listening. I don't know. So he's one person who helped me in preparing and getting the slides so that I could present. So I would like to thank him for that. The slides, most of them is not done by me. I have to, that is a disclaimer. I have to do it. I should have done it in the beginning, but I couldn't. Thank you so much.
So nice of you. Thank you very much. And I would also like to thank our product manager, Mr. Amol, for joining this particular session and helping us with the technical support. Thank you very much. Wishing you good night and take care.
Thank you. Good night.
Good night,
Thank
sir.
you. Thank you, Saurabh. Thank you, Anmol, Jidesh, and Rajesh. Bye.
Thank you. Thank you, doctor. Thank you, Dr. Jitesh.
Okay.